Hello everyone, it is 12:30, so we are going to go ahead and get started. We have a great presenter today, a very sought after topic, something that we're going to hopefully do more of throughout this year, and I'll speak to that a little later in my introduction here. If anyone is having problems hearing me or our presenter, you can let me know. You can chat with me and I'll walk you through that in just a second, or you can send me a text message. Some of you have already been doing that. So if you have any issues throughout our presentation, let me know. We've been having some issues with people trying to watch through Mozilla, and Mozilla is requiring some kind of WebEx add-on that isn't running very well. So if you're trying through that and not having much luck, try either Internet Explorer or Google Chrome is not having any issues at the moment. So if you're having a WebEx issue, it might be you're trying it through Mozilla. For those of you listening live and for anyone listening as a recording, there's no video component for this, so you shouldn't have a little video box pop up where if you have a webcam, it'll let us talk. That should be turned off. If you get one of those, just X out of it. We are now offering live and recorded sessions, Category 1 CME credit. This qualifies for 0.5 hours. If you're listening live, you can go to the calendar appointment that this webinar link was sent to you with, and there is a CME survey in that calendar appointment. If you're listening to this as a recording on our YouTube playlist, you can go to the video notes section, and at the bottom will be the link to this survey for CME credit as well. At the end of the presentation, I'll walk you through how you can go in and see how much CME credit you've received from Carilion through our CME tracker system. We also have a certificate of completion that is in the surveys as well. If you're not specifically looking for CME credit, but you want to have some proof that you logged in and participated in this, you can get that as well. For questions during the presentation, you will notice that when you log on, the phones are muted. So we do that so we don't get background noise, or if someone's driving, we don't hear what's going on your end. I will keep those muted until the very end, at which time, if we have time left over, we'll unmute the phones and we can have verbal questions or discussions. If you have a question during the presentation or you want to make a comment, you can use the Q&A button that's in the top, or excuse me, the chat button that's in the top left side of your screen. If you find the participants, chat with Alex. I'll be monitoring on a side computer, and I'll be able to ask Heather the questions as we go if it's something that can't wait till the very end. This is my contact information. You can email me here. This is the easiest way to get in touch with us, outreach@CarilionClinic.org, or you can call the office number here. Always looking for ideas for future presentations. Like I said, I'm hoping we can get some regularly occurring information out about this topic and some other forensic nursing topics, because those are always very popular and in high demand, and we have a great team here that I think can fulfill that. So we're going to work on that throughout the year. If you have other ideas for topics or other education you need, or if you're listening to this and you're a referring provider or a regional provider or clinician and you have a question or you need to interface with Carilion Children at all, you can always reach out to me, and I'm happy to serve in that capacity. Some quick upcoming plugs. Shameless plugs for myself here. We do this monthly lunch and learn session from 12:30 to 1. It's kind of bite-sized. We're trying not to fill up a whole hour, so it's really boiled down into what exactly you might need to know. Might not hit everything from that topic, but really trying to hit the high points. So you'll see as this goes on that it's really condensed down to the shortest version we can to be respectful of your time and to fill this in over some lunch hours. We also do weekly Pediatric Grand Rounds webcasts. We have one tomorrow. They are at 7:30 on Thursday mornings. You can find everything that we do and record and put out on our Carilion Children's Outreach playlist. If you just go to YouTube and you type that in the search box, Carilion Children's Outreach playlist, you will find us. We've got close to 100 videos now. Like I said, we are starting to offer Category 1 CME credit for all the videos released in 2017, so that's a great upgrade to our system. And as always, if you want to be added to our outreach network, you will get these calendar appointments for the webinars that we do. We also release podcasts. We release information, blog posts, all kinds of stuff about local issues, local resources with some local experts, and we'd be happy to add you to that list if you are interested. Enough about me. Let's talk about why everyone is logging in. Today's presenter is Heather Smith, and she was already correcting me about her picture here that I snagged off of LinkedIn as my first connection with her, or a first degree connection with her. So she is a forensic nurse examiner at Carilion Clinic, and she is going to be talking about the initial medical response to child sexual abuse. So thank you very much, Heather, for joining us.
Thanks, Alex. I appreciate you all taking the time out of your day to discuss and review the initial medical response to child sexual abuse. I am filling in today for Christina Rouse, who I'm really not worthy of replacing, but she and other members of our multidisciplinary team did put together parts of this presentation for the Pediatric conference in December. So just to review our objectives for today, I want to define pediatric sexual assault, review the statistics of pediatric sexual assault in Virginia and the nation, describe where pediatric sexual assault victims present. We're going to discuss mandatory reporting, and we're going to review a response algorithm. What isn't included in the objectives today is how to recognize ped sexual assault. My mentor, Melissa Harper, did a webinar that was published on the Carilion Children's YouTube channel, which covers recognition. It's awesome, and you should really check it out. Before we jump right into this, I'd like to take a few minutes and listen to why we care. Why are we doing this? And just give me 1 second while we pull it up.
My eating, with anorexia, I purged bulimia. I guess we also were hoping the phase would go away, and I really started contemplating thoughts of suicide, and actually attempting suicide. And this pain was so deep that her first counselor just broke down in tears after months of this and pretty much said, I don't know what to do. And I remember doing every single thing they told me to do. I did every homework, and I'd come back and I'd say, I still want to cut and I still want to restrict. We were getting quite hopeless because the very days it seemed that she would be at the counselor, she would come home and she would have some of her worst cutting incidents. Everything that a man could do, nothing seemed to be touching the core of Hannah, and she basically just wanted to die. So I would just run through the ways in my head that I'd failed, the reasons why I was guilty, why I was worthless, why I was ugly, fat. So I felt that I needed punishment for I had failed my family, I'd failed myself. I guess this is where I felt things totally out of control because
So why do we care? Give me a second while we pop back to the presentation. Why do we care? Because we as healthcare providers really are the gatekeepers for these kids and their families, and we can help change the trajectory of their lives and their future generations just by taking a minute and listening and connecting them to resources that can help them with recovery. Not only does it affect their health, but it affects also their emotional well-being, their intellectual and cognitive development. So this is an infographic that is from the National Child Advocacy Center that shows the economic impact of child abuse. This is part of, why do we care, besides the obvious. So the annual medical costs for survivors of child sexual abuse costs 16% more than it does for people who haven't suffered from child sexual abuse. Survivors are significantly less likely to own a checking account, own a home, own a car, or to buy stock. And this number down here, this huge number, basically tells us 9% of all Medicaid expenses is directly related to the medical care of child maltreatment. So I guess we need to start off, before we can figure out how do we respond to it, we need to talk about what is pediatric sexual abuse. The Code of Virginia is slightly intimidating. So instead of, I did add the statute there that you can reference, but I also included the Virginia Department of Social Services, DSS, information also that describes what pediatric sexual abuse is, and it includes sexual exploitation, specifically allowing, permitting, encouraging a child to engage in prostitution and or pornography, sexual molestation, intercourse, sodomy, and they had a general other catch-all term of sexual abuse that included solicitation of a child for the purpose of sexual arousal, stimulation or gratification, and exposing yourself, or forcing a child to watch sexual content. So what's the prevalence? We're talking about it. What does it look like nationally, and what does it look like at our local level? So the first two numbers are from 2014. The Children's Bureau reported that 702,000 children were maltreated. 88.3% of those were sexually abused. In Virginia, in the same time frame, 6,464 children were maltreated. 804 of those children were victims of child sexual abuse. These two numbers, it was hard to get really concise information at the local level, but Roanoke City Department of Social Services reported that their year-to-date in 2016 that there were 47 kids that were victims of child sexual abuse. And in Roanoke County, the police department reported that there were 32 victims in 2016. So how do these kids get reported? The majority of children, or the majority of disclosure is made to mandated reporter who calls CPS or law enforcement. Some families respond directly to the hospital. We can look at the graph in Roanoke City. The majority of kids or reports that are made about child sexual abuse come from the school. They go right to the either their primary care physician or the ER, and the police have sent them. In Roanoke County, the majority of reports are made from the school, with the second part as an other, and closely followed is the police and parents. So let's talk about mandated reporting. I guess you have to know who a mandated reporter is, and when to report, and what happens if I don't report. So Virginia defines mandated reporter and their responsibilities. Mandated reporters have to report immediately any suspected abuse or neglect that they learn of in their professional capacity. No one is required to make a report on the same matter or the same report of sexual abuse that they know for sure that someone else has called either the toll-free child abuse hotline or talked to the Department of Social Services. Also, mandated reporters shall disclose all information that supports the report. So basically, any documentation that you have that supports your report, you need to be able to make that available. So what happens if you don't? Mandated reporters failure to report as soon as possible, but no longer than 24 hours after having reason to suspect a reportable offense of child abuse or neglect shall result in a fine. And anyone who knowingly and intentionally fails to report shall be guilty of a Class 1 misdemeanor. So this is definitely not an all-inclusive. I couldn't fit the whole list. So I just kind of highlighted some of the obvious mandated reporters and some of the not so obvious ones. Anyone who is licensed to practice medicine or any of the healing arts, residents, interns, anyone employed in the nursing profession, social workers, probation officers, teachers, child care providers, mental health professionals, law enforcement officer or animal control officer, interesting enough, mediators. I thought this was interesting. Medical service providers or emergency medical service providers, unless such a provider is immediately, once they get to the hospital, they tell an attending physician who they know will make the report. Athletic coaches and directors, foster and adoptive parents, and respite care providers. So we did a lot of back work to get to this response algorithm. This is from the National Protocol of Sexual Abuse for Medical Examiners, and it can be found at www.kidsta.org. And it basically, so we're going to skip over the first part of it. Onto the far left is how do you respond if you are CPS, law enforcement, or 911. The middle of it is if you're an advocate or someone who provides victim services. And we're going to look specifically at if a disclosure of child sexual abuse is first made to a healthcare provider who does not have specialty care training for child sexual abuse. So I'll stop here and just say that the gold standard for care of children who have been sexually abused is someone who is specialized in it. And we'll go into what your resources are in our area in a few minutes. So we're going to talk specifically about the initial healthcare assessment and triage of the child by a healthcare provider. That I kind of popped this out just so that we could look at it more specifically. So if you have a kid that comes into your primary care practice or wherever you're providing care to a child, you want to prioritize that child. You want to gather a minimum history. I could speak at length about history gathering and give details about history gathering, but basically you want to get information that will allow you to make a good decision about acute versus non-acute care of this patient. You want to call and make sure that mandating reporting and communicate any safety concerns that you have. You want to do an initial medical screening exam. You want to evaluate for acute injury. You want to look for pain, bleeding, and stabilization of any acute things that present. You want to preserve the forensic evidence on a child's body. So if you can, if you know that it's acute or it's occurred in less than 72 hours, try to, like, you don't want them to pee, you don't want them to have anything to drink, but do the best that you can while still making a child comfortable. If they have the clothing, if they take it off or they bring it with them, you can put it in like a paper bag and make sure that it goes with them when they go to get emergent care. And as always, I'm not trying to say that forensic care in any way, shape, or form supersedes urgent treatment. It doesn't. Forensic evidence preservation does not supersede emergent treatment or stabilization of a pediatric patient. You next want to determine the urgency of care needed, so acute versus non-acute. We're going to review that in a minute. And give a forensic medical provider a call and let them know what's going on. And if you have an advocate in your area, you can give them a call. So let's look at acute versus non-acute. This is going to determine how quickly you get a patient to a forensic nurse, and in our area, a forensic nurse. So an acute exam falls under the criteria of reported sexual abuse in less than 72 hours, or if it's an unknown time frame, or the chance that there's still biological or trace evidence on the patient, and that is, you know, that mom said that it's been, you know, they haven't given the kid a bath in 5 days, or, you know, something outlandish like that, or if the time frame is greater than 72 hours and there are symptoms of injury, for example, pain, bleeding, obvious signs of an STD, if there's a history of abduction, if the child is suicidal or homicidal, or the child or the caregiver has concerns that an acute exam can address, or if you feel like the patient is at risk of imminent danger, or sadly, if you have a concern that you don't think that the family will return for a non-acute exam. And then just basically what doesn't fall under an acute exam is everything else, and if it's happened in greater than 72 hours. So this is from the national protocol also, and it starts out with, this is just basically an algorithm of what I summarized before, but what I wanted to point out in this specifically is, although you may not be as a medical provider doing these things, just to give you an example of what an acute exam includes. So it would be obtaining consent from the patient and the family. And I always stop when I talk to families, you know, a forensic exam shouldn't hurt. Like, we are a child-friendly environment. We have child life specialists. We have, you know, an iPad. And doing a head-to-toe exam is no different than doing any other head-to-toe exam. And when we get to the anogenital part of it, we really take time and slow down and explain the exam to the patient and the family. And if at any time I get to the point where I have a 5-year-old look at me and say, no, you're not going to do that, then I stop. Because really, to me, what's more important is the outcome for the patient than it is for gathering the evidence. I'd like to do both, and I'll do my best to encourage them to have the exam, but really consent is first and foremost for us. We'll make sure that the mandatory reporting is done. We'll contact, as appropriate, child CPS and the police. We'll get a detailed medical history and do a head-to-toe physical and anogenital exam. Something that includes is looking at their anogenitals with a colposcope, which has a camera and can do some magnification. We'll treat any injury or disease. We do documentation for medical and legal purposes. Part of what we also do is collection of forensic samples. There's also a very extensive algorithm about testing for STDs, including HIV as appropriate, and administration of prophylactic medication as appropriate. And then we take the time during discharge to set up their follow-up care, make sure that they have a provider to follow up with, that they're safe, that they have referral to counseling, and that they have some support. So the difference in a non-acute exam that we said was in greater than 72 hours is you give us a call and you talk to the forensic nurse that's on, and you get the information, and we'll call the family and schedule an exam when it's convenient for the family. They don't have to come in right away. So let's look at collection timeframes. So this just recently came out from the Virginia Department of Health that tells us when we can collect evidence. Some of the timeframes have increased. It goes on type of assault and then maximum collection time. So for external, it would be cunnilingus was greater than 96 hours. Saliva on the skin is within 96 hours. Strangulation would be within 48 hours. So if you had vaginal assault with penile penetration, it is up to 5 days. and digital penetration on the and including the thighs and external genitalia sample would be within 48 hours. If you had penetration of the anus by a penis, it would be within 72 hours. Digital penetration within 48 hours, and then an oral assault within 24 hours. So a really good friend of mine always reminded me that you don't have to know it all. You just have to know your resources. And first and foremost, we as a forensic nurses are only a phone call away. That's what we're here for. I will never, I'm always glad to take a phone call from a medical provider that has a question about, evidence or, what do you think about this, or who should I talk to about this? Other resources include Child Protective Services, law enforcement, victim witness. We have a wonderful child advocacy center here in town. You can refer them for counseling and other community sources. So in forensic programs here with Carilion include, we have a forensic program here at RMH and our ER, at Carilion New River Valley, and at Carilion Franklin Memorial Hospital. So these are the numbers that if you have a question and want to talk to a forensic nurse, are the contact information. Alex just handed me, oh, gotcha, okay. And so you can call the main hospital number here. If you have an immediate need, you can call MedCom. And this is the forensic nurse office, and you can leave a voicemail and someone will get back to you. So I really, really appreciate you taking the time to listen today, and I am going to hand it back to Alex.
Thank you, Heather, for pulling that together within less than 24 hours notice. I think that's incredibly impressive. If anyone has any questions, I'm going to go ahead and unmute the phones now and we can have discussions. I've been getting a few questions and comments coming in, but I think we've covered most of those items along the way. But if there's anything else anyone has questions about, please let me know. So I'm going to go ahead and unmute the phones now. If you don't have a question or if you don't want to make a comment, please just put your phone on mute so we don't get any background information.
The conference is now in talk mode.
Okay, so the phone lines are unmuted. Hopefully I didn't kick everyone off when I hung up on everyone. So does anyone on the line have a question for Heather or a comment for Heather? I'll go ahead and keep the phones unmuted here. The few questions that I have received coming in, there were two that I think we can talk about now. One being how, if you're a non-Carilion person listening to this either live or as a recording, how would they get information about other forensic programs maybe in their community or around their community? And then there was a question about contact information, but I think, I'll throw this back up here. I think the contact information is right there. So Heather, do you want to speak to what would a non-Carilion or a community provider, medical personnel, how would they go about finding a forensic program in their community, or what resources do you recommend for that? And I'll do this without hanging up again, I promise.
Thanks, Alex. So within our general region, the only, besides the Carilion sites that I mentioned before, the only other forensic programs in our area are at Lynchburg. And if for some reason outside of our general area you're hearing this, please feel free to call the numbers listed here, and I can help you hook up with a forensic nurse or a forensic medical provider in your area.
Okay, I did it without hanging up. All right. If there are not any other questions, I'll give it one more round. We will go ahead and wrap this up. Just a reminder, if you're listening live, this does qualify for Category 1 CME credit, and you can get that credit by going to the survey, the calendar appointment that you got this webinar info from. There's a survey link in it. Fill that out, and it'll automatically drop to our CME tracker system. If you ever want to see how many CME credits or hours that you've got, you can go to our CME webpage, which is right here, and it's a long title with you got to put the dashes in it to get there. But there's links to our CME tracker system. It's an online portal that lets you know how many hours, what classes we have, and if there's ever any issues, you can always email us. If something isn't showing up on your record that you did, we can always go back and see if there was a problem or if it just hasn't been processed yet. If you're listening to this as a recording, go to your video notes section, click on that little drop-down menu, and you will see the survey information there. So if there are no other questions, again, I hope you have enjoyed kind of our lunch and learn format, bite-sized amounts of information. So hopefully you guys can have taken something away from this. If you do have any questions for Heather that you didn't ask or that you come up with later, you can always email me at outreach@carilionclinic.org, and I will get them to her, and we can start a dialogue that way. With that, we're going to go ahead and disconnect the phone lines now, and thank you all very much for joining us.